Welcome and thank you for joining us today. Our research team is doing a video series on the topic of multiple long-term conditions, also known as MLTCs. And this is going to be our first video discussing an introduction to MLTCs. So we're joined here today with a fantastic panel of experts, which I will introduce. We've got Dr. Deborah Ikhile, got Dr. Ash Routen, and Dr. Lauren O'Mahony. And I myself, I'm Dr Ghanshyam Kacha. And we work here at the Leicester team, the Leicester National Applied Research Collaboration with the NIHR. And we also have the Global Health Research Unit in Leicester. So let's start by defining what MLTCs are. So I think that's an important point to cover first. So I'd like to ask Lauren, how do we define MLTCs?
So that's a very good question, Shyam. I think the simplest definition of MLTCs would be anybody living with two or more long-term conditions. Although that sounds fairly simplistic, it's actually not. It's very complex and very difficult in research to try and manage. But chronic conditions, for example, diabetes and hypertension, cardiovascular disease, or other conditions such as schizophrenia, depression, all of these fall under the umbrella term MLTC, and it's just a person who's living with two or more. They could have five, they could have less or more, but the minimum is two.
Yeah, that's a really good point to cover, is two or more long-term conditions. But like you said, it's a bit more complex than just that. So Ash, what would be included in this list of conditions, let's say?
Yeah, that's a complex one. There is no universal agreement on what set of conditions should be included. And a recent systematic review of over 500 studies on multiple long-term conditions found nearly 300 different conditions being included under the banner of two or more long-term conditions. And obviously that causes an issue for researchers who are looking to have comparability between studies, but also for policymakers. If we're not all talking about the same thing, how can we implement effective policy? And in some sense, to try and remedy this inconsistency in the set of conditions included in the definition, a Delphi study, which is a consensus study, has been utilised, whereby international experts have been convened to come to some kind of agreement as to what conditions should be included in a core outcome set. Now, that piece of work solidified around 35 conditions that should usually or typically be included in multiple long-term conditions research. So that's a good basis for people working in the field going forwards.
Yeah, okay, that's really good. So I guess a lot of work is being done in this area. Which long-term conditions count as a long-term condition?
Yes.
In terms of MLTC, but you mentioned recent study showing, Delphi study showing we should be considering there's a list of 35.
Yes.
And I guess commonly we can think of conditions like diabetes, hypertension, but it also includes mental health conditions that are long-term. So there's things that maybe we may not initially think of as well. So that's really good. Deborah, just on the definition, is there anything else you wanted to add?
Yeah, just to also touch upon what my colleagues already said, Ash and Robin, about it's been a complex concept. It is complex, and beyond it being a clinical diagnosis, there's also the lived experience of the individual. So it's just beyond saying that, someone has got, say, depression and diabetes or hypertension, for example, thinking about their neighborhood as well, thinking about how all of this affects their experience of the disease or the conditions of MLTC in them. So it's very important to know that MLTC, yes, it's about two conditions, but it's also about the lived experience of the person, and the social environment also matters and plays a key role as well.
Yeah, no, that's really good. I like putting the patient at the center of what we do and, how we define things. And so that's a really good point. So that brings us on to a very important point around MLTCs, the terminology we use. So there are different terminologies being used by researchers and clinicians, and a lot of people may be familiar with MLTC, but some people are more familiar with the use of multimorbidity as a term. So I'll start with you, Ash. Why are we Why do we use the term MLTC?
So language really matters, and it really matters to patients. Multimorbidity has been the prevailing term in the clinical, the academic literature for a number of decades, but patients and advocacy groups have some issue with this phraseology. In particular, they feel it's clinical, reductionist, slightly pejorative because of the focus on morbidity. It has negative connotations. So our group has done some work to try and better understand what patients would prefer in terms of the terminology, and not surprisingly, multiple long-term conditions appears to be the preferred term. We've published that work in the British Medical Journal, but it's well uptaken and adhered to by researchers in the field now, I think, and NIHR being one as well.
Yeah, that's true. I think it's gaining traction and people are more aligning with the use of MLTC as a word. And what's your feelings about it, Deborah, with the use of terminology?
I agree with Ash. I mean, from years of engaging with communities and people living with long-term conditions, there is this sense of disempowerment when you see someone is multimorbid. Then it makes them feel stigmatized and victimized. So when you refer to MLTC, then you kind of empower the person, and it's more about the person, not the condition. So it is a less stigmatizing term to say that, a person living with multiple long-term conditions than saying someone who is multimorbid. So it's also about how you make people feel they have control or not over their conditions. And certainly MLTC is a much more empowering term than multimorbidity.
Yeah, and I think it makes a lot more sense, like working in clinical practice, like Lauren said, is 2 or more long-term conditions. So if somebody has asthma, depression, I wouldn't necessarily straight away say they've got multimorbidity.
Exactly.
It sort of causes confusion. So definitely agree with all the points. And so, Lauren, another word, term that's often used is comorbidity. And how would you separate the two?
Yeah, so I think it's really important that you've touched upon that, because comorbid and multimorbidity, they're 2 separate things. So back in recent years, and the word or the term comorbid has been used when a disease has been given its own index. So, for example, diabetes, hypertension alongside that would have been classed as a comorbid condition, whereas one we're trying to move away from the morbid term in all senses of the definition and anything to go along with it. But it also means that we can treat those conditions more easily, rather than just treating one condition, for example, the diabetes, and kind of sidelining the hypertension slightly. It leads to quite fragmented care, and we're hoping to move towards a more integrated approach.
Yeah, no, that makes a lot of sense. So comorbidity, I agree, it's a term still used often in clinical practice, but there's no real reason to prioritize one condition over the other sometimes. And
absolutely. I think patients feel quite strongly about that as well, that one condition doesn't always necessarily take precedence over another, and they want both to be treated with the same regard.
Yeah, it's more holistic, and I think it's a little bit better to think about it as a group of conditions, because there can be a vicious circle sometimes, and what's causing what is hard to define always, isn't it? Yeah. So that brings us on to another question, which is, how common is MLTC? What's the prevalence? How is it affected by age, sex, ethnicity, things like that? So I just wanted to start by discussing a recent paper that was published, and they looked at 60 million people in England, so quite a large data set, nearly the whole population. And when they looked at MLTC prevalence, they found it to be 14.8%, which is quite a lot in itself. 14% of the population has MLTC. But when you look at people who are over the age of 80, the majority of them may have MLTC 70% or above, which is kind of what you would expect. But Lauren, what would you say about age being a driver for MLTC?
I think age is a huge driver, and as you mentioned, it does seem that there's this reciprocal shift in age and the prevalence of MLTC. But do you think that we're noticing the prevalence of MLTC in younger populations. It's not just what would not like be termed a geriatric area of research. I think we're seeing it more and more in younger populations, not just those over 70, for example. I don't think it's the only driver either. I think that people in deprived areas are at significantly greater risk of developing MLTCs. I think that roughly the risk of developing MLTCs is around 10 to 15% higher in those from deprived areas compared to more affluent areas, which, is a real social injustice and an area of research we really need to be focusing on.
Yeah, that's a really good point. So it's not only age as you get older, it's also other factors such as, like you brought up importantly, deprivation can affect how likely are you to have MLTC. And quite shocking to hear 10 years younger. 10 to
15 years, yeah.
10 to 15 year gap between least deprived, most deprived. So that's an area to really look at, isn't it, in MLTC. So Deborah, there's also other factors such as ethnicity which may affect MLTC.
Definitely, yeah, and that's also linked to even deprivation as well and neighborhoods, because we know already from years of research that certain ethnic groups tend to live in certain neighborhoods, and it's not just about MLTC. Ethnicity has been linked to deprivation, in different health conditions. So coming back to MLTC, and I guess I won't stop using the word complexity. It makes it a bit more complex for people from certain ethnic backgrounds. So, for example, people from South Asian groups are more likely to have MLTC, and for conditions such as diabetes and cardiovascular diseases, because already, even as single conditions, these tend to occur more in this population. So when it is then clustered, which means it is kind of occurring together at the same time in one individual, then there is a higher burden in those populations. Interestingly, for the Black African communities, there seems to be little data on the prevalence. And, based on the evidence that we know of at the moment, we feel this is more about underdiagnosis, not a true representation of the burden in this community, because, again, there is enough evidence from research pertaining to single condition that there is that disproportionate burden of certain conditions in Black Africans than the white counterparts, for example, like breast cancer. So we also know that if you look at the MLTC trend, it is likely to follow the same pattern as well. So the whole concept of MLTs, like I've said before, and like my colleagues keep on saying, it is complex. When you think about sex, you think about age, ethnicity, it just makes it more complex. And then you then try to understand or appreciate the burden and how it affects people differently. Then knowing that MLTC does not affect the population in the same manner, and the manifestation and experiences would differ across populations.
Yeah, so that's really good to hear, and I was quite surprised to hear there's not that much research in certain ethnicity groups. So, that we don't know there are some gaps in research.
And we need to focus more on that going forward. It just shows that there is gap in this area, which then means that as researchers, we need to be doing more in this area to kind of bring together that body of evidence to drive the change that we want to see.
Yeah, it's quite good, yeah. So there's another thing to touch on with the prevalence is gender. So Ash, does male or female have any effects on?
Yeah, so looking at sex alone, it does play a factor in the prevalence of multiple long-term conditions, but the findings, as with a lot of epidemiology, are mixed. So if we look at some studies, they suggest that under 60s, women have higher prevalence of multiple long-term conditions compared to men.
Okay.
Some possible explanatory factors can be things like autoimmune conditions, chronic pain, for example. But when we start to look at older ages, so over 60, that gap narrows, and in some cases it reverses. And that's, of course, just age alone. And Deborah alluded to the complexity or the intersectionality of these factors that we've discussed. When you start thinking about age, sex, ethnicity, deprivation interacting together, then it changes the picture, very much so.
Yeah, so there's a bit of shifts through different groups, and it's quite interesting to hear that maybe female gender is more affected, then it switches a little bit. So, it's quite interesting.
Absolutely.
But we probably don't know everything about it in that area. So, Lauren, there's also this idea of clusters and combinations and things that's important to look at when we're studying MLTC.
Absolutely, yeah. And I think the diversity of condition combinations is what makes MLTC why research and management and everything that we're interested in so difficult is there's just a sheer number of different combinations. So in the study that you referred to earlier, just in the 80 and over population, there was over 200,000 different combinations of two or more conditions, which makes it so difficult to come up with a one-size-fits-all approach to research, management, care, whatever it may be. So there's a real need for that personalised care approach within the MLTC area, which we can see from all of these different combinations of diseases.
Yeah, so it's quite a large number, isn't it? 200,000 combinations.
And that's just in the 80 plus age group. So
yeah, so it's more complex than we imagine it to be, because when you hear it's two or more conditions, but you can actually go a lot deeper into it. So it's interesting to hear those kind of numbers. So when we look at MLTC, we know that it's very prevalent. There's many people who have it. So what kind of challenges do people with MLTC face? So I'll start with yourself, Deborah, if that's okay.
Yeah, I mean, the main challenge is still the fact that our current healthcare system is fragmented and it is set up to address single disease or single conditions. I mean, and that is not a failing on our healthcare system. That has been the trend historically, but obviously there's been a change, in conditions, and now we are seeing two or more in one individual. So the fact that the health system is still structured in that way, such that, for example, someone who's got heart disease is in the cardiologist, depression is in the psychiatrist, and they're not talking to each other, it means that, the individual is left facing different specialists to address or to meet their needs. And all of this adds to emotional burden, it's time consuming, the strain, and even sometimes getting confusing advice from your specialist as well as its own impact on the lived experience of that individual. So the main challenge still remains that the current setup of the healthcare system is focused on, dealing with conditions in silos. So we are still not at the point where we have taken a holistic approach, towards addressing MLTC.
Yeah, no, definitely. I definitely agree with everything you said.
Yeah.
Working in general practice, often there's a lot of confusion, different referral pathways to different specialists, the model that we have doesn't often fit well with MLTC.
And navigating that pathway for an individual is cumbersome.
Yeah, you're right. And coming on to that, navigating the patient experience or the person experience, Ash, you've got something about how many appointments people have to attend to and things like that.
There is a body of evidence around the idea of appointment overload. One particular study has suggested that people living with 4 or more long-term conditions over a 2-year period have on average 29 appointments, which is quite a lot when you think in comparison to people living with just a single condition have 10, so 19 less. And of course that's time consuming for the patient and the clinician, and there's the associated cost burden. And of course, time and money are some of the most pressing challenges for our health service at the moment. So that's a real concern. Yeah,
I guess you may imagine they have to attend more appointments, but when you hear these numbers, it's a little bit, it's a bit shocking sometimes to hear that they have to attend so many appointments. And it goes back to your point, Deborah, that our healthcare system sometimes works in silos. There are individual departments. And sometimes people may have to see each individual department
for different conditions.
Conditions. So,
definitely.
I guess that is a big challenge in MLTC. There's also another big category of challenge, Lauren, about polypharmacy.
Yeah, polypharmacy is a major issue. It's where an individual is prescribed multiple medications, and it can often lead to increased side effects, adverse events, hospitalisation. It's really common in multiple long-term conditions, with some patients taking 10 to 15 different medications at once. But the challenge is that most clinical guidelines are disease specific. So it will be, if this hypertension drug, this is how you should prescribe it, and it's very prescriptive. But it's very siloed as with the healthcare. Then another guideline will give a very specific guideline, but they don't talk to one another. There's no interaction, which makes it very difficult to manage any drug interactions, side effects. And it's just a real issue with polypharmacy, particularly for patients. Like, patients don't want to be taking 10 to 15 medications. But what tends to happen is, you'll find a drug that is effective for whatever, symptom A, but then it causes symptom B, and then you find a drug that, is effective for symptom B, and then before you know it, the polypharmacy is ridiculous, and it's difficult for the patient, it's difficult for the GP, and obviously there's cost implications, so it is a real issue.
Yeah, no, I completely agree. I mean, when I see patients, it's not unusual to see people on 10, 15 medications. So, I mean, I can, imagine the amount of issues that sometimes could cause remembering to take medications and the amount of reviews they need on the medications. So everything sort of builds up and it seems to impact on each other,
I think there's like certain medications that you can only take in the morning, you can only take in the evening. It's not like they can just set one time a day when they get up in the morning, because they might need, at different time points. So it's then got that added level of complexity again, which is just so difficult for the patient to manage.
Yeah, because even remembering to take one multivitamin is like we all forget. So it's difficult for people to manage so much. So I think moving on from the challenges, I guess the next question is more about what we're doing about it. I mean, in terms of what is the NHS, healthcare systems, are you aware of any initiatives that are going on? I guess the one thing I've seen more recently is there's just more awareness of MLTC. I think the healthcare systems departments are realizing that this is a kind of large-scale issue. And there's been mentioned in the 5-year forward view that MLTC is a priority. And I guess that is something that needs to be kind of thought about a lot more. There's also other initiatives, but Deborah, is there anything that you're aware of that you've seen?
Yeah, so thinking about the Core 20+5, so in 2021, the NHS put forward this framework, although it's focusing on addressing health inequalities, but again, like we've discussed today, MLTC is fraught with inequalities. We think about this sex disparity, ethnicity, deprivation. So what the Core 20+5 is really saying more or less is that, going forward, the healthcare system will focus on the 20% of population who are in less deprived neighborhoods, and focusing on the plus is additional groups that may not have access to healthcare, say, for example, people with learning disabilities as an example, and then focusing on 5 key conditions around maternal health, severe mental illness, cancer, early cancer diagnosis, hypertension, respiratory disease. So whilst this framework kind of targets on single condition, it provides an approach for start thinking about how we can leverage on this to manage or to intervene for MLTC as well, knowing that MLTC occurs as clusters. So, for example, someone with cancer and hypertension, the Core 20+5 can be a good framework to then see how can we look at managing this person within this framework, again, bearing in mind that disparity or inequalities lens. So it is still work in progress. We are not there yet, but at least there is that framework that we can start to think about how do we leverage on existing platforms and frameworks to start addressing on MLTC, not starting something completely different or new, which is going to be very, very expensive, but what kind of cost-effective approaches can we take based on what we already have in place?
Yeah, it's really interesting kind of you brought that up, because we discussed before how inequality impacts MLTC.
Definitely.
So it's sort of tying into these things.
Yeah.
So that's really interesting. Okay, so there's also this idea of personalized care that we may have heard of, that there is a sort of up and coming area. So Ash, is there something in that area you've heard about? Or?
Yeah, so universalised personalised care has been enshrined in the NHS long-term plan now. And in essence, it takes the approach of, rather than saying, what's the matter with you, we ask the patients, what matters to you primarily. So instead of thinking about people as just treating their diseases, it's treating them as an individual. And a kind of fundamental principle of that is something called shared decision-making, where patients are let into what the healthcare means, and they're also let into making shared decisions on their care, which is really important because it gives patients a sense of control and autonomy, and hopefully through the shared decisions potentially a little bit more coherence in the healthcare journey. An example of how this might play out is there are things such as personal health budgets, where patients are allocated a certain budget to be able to spend on therapies and interventions that they would like to choose. It could be linking up through social prescribing to efforts in the community, for example. So it's much more a shared decision-making approach, personalised to the patient's needs. It's more respectful.
Yeah.
Hopefully greater feelings of control, respect, autonomy and so on in their journey.
Yeah, those are really interesting points. I think it ties back to when Lauren was talking about the vast combinations, that tells you that each person with MLTC is an individual, and so we should approach it with this personalized care and, what matters to them rather than what matters to you, it's taking their viewpoint as a central kind of part. It makes a lot of sense, I think. There's also what I've been seeing is the use of electronic health systems, health records, technology. And Lauren, have you seen anything in that area?
Yeah, we have seen a lot of investment recently in digital solutions and, like you mentioned, electronic health records and using AI tools in particular to help try and identify clusters of MLTC, people who might be more prone to developing MLTC, more likely, based on AI methods. And then how we can use that information is to intervene early and try and prevent them from, developing more conditions, try and manage them better. So I'd say that's where a lot of the research is sort of focused at the minute in terms of technology, is on AI tools to develop like risk stratification.
Yeah, that's really interesting, and I guess we're quite unique because we have a nationalised health and electronic records. So we're quite lucky to have these to work to test out different things.
Absolutely, yeah.
It's interesting to hear how applications of technology to predict MLTC might be the future potentially. Yeah, it's really interesting. So one of the final things I wanted to ask is, we've sort of learned today discussing it that MLTC is a very large topic. It's hard to cover it in just one session. But what particular areas are you guys interested in? So what are you working on? What's your kind of, something that interests you about MLTC? So we'll just go around the table, if that's right, starting with Deborah.
Yeah, sure. So my research interests and what kind of work I've been working on in the past couple of years have been around MLTC prevention and health inequalities. So focusing mostly on those minoritized ethnic communities, South Asians and Black Africans, and trying to see how to prevent or manage MLTC in this population. Recently, I'm conducting a review to see which interventions have been conducted to manage MLTC in Black Africans and South Asians, across the OECD countries, and that is currently in progress. And what we see at the moment is there isn't much out there focusing on people from certain communities. So while, of course, there is that increasing evidence around MLTC interventions globally, but we still see that there is a huge gap when we come down to ethnicity focus. So going back to the link we made earlier on around ethnicity and MLTC burden, that's also affecting the trend around MLTC interventions and management. And one of the things that I've been doing as part of my work is also engaging with local communities as well, trying to see what matters to them, people with lived experience of MLTC, whether because they have those conditions or because they are caring for people who have MLTC, and trying to get their voice into research as well. And one of the key messages that they keep owning on is the issue of trust. That trust is very important. Any MLTC intervention that would be implemented for certain communities, those from different ethnicities, has to be one that is grounded around trust, otherwise it's not going to be acceptable and it's not going to be implementable. So it's very important to know that going forward, trust is very important to assess these communities. I'm also interested in MLTC research from a global health perspective. So I've done some work in Africa, and I'm part of the Global Health Research Center for MLTC, which which is hosted here at Leicester. And again, that's focusing on doing MLTC management in India and Nepal.
Okay, so yeah, it's very interesting, your area of research and looking at ethnicity. And I really like how you're working closely with the groups as well, getting
Because when it's about them, like Ash mentioned, that person-centered care, shared decision-making. Sometimes as researchers, we make the mistakes of doing research for communities and not with them. And, we need to change that approach if we want them to be empowered, if we want the research to be meaningful, if we want it to actually have, that practical impact and be translated into practice. Then we need the voices of those who are actually affected by those, by those conditions or issues to start to shape the research that we focus on going forward.
Yeah, it sounds like you're doing really good work there. And just to move on with Lauren, what kind of things you've been working on?
So one of the areas of research that I'm probably most interested in MLTCs is looking at lifestyle modifications to help prevent or manage MLTCs, and that's one area of interest that I'm particularly interested in. But one of the main pieces of MLTC work that I've been working on recently is an umbrella review on core outcomes for multiple long-term conditions. So what we often see in research is lots of researchers will do lots of different projects, and none of them will really speak to one another about certain tools that they're using, what is outcomes they're measuring, and when we try and put all of the research together to kind of come up with a final conclusion and make some sense of it, it's very difficult when they haven't used the same outcomes, and then that then has an impact on how useful that the research can be, how much use it is to patients. So what we're hoping to do is sort of bring all of these core outcome sets together that have been developed in different areas, whether it be in low and middle income countries, whether it be in primary care, secondary care, wherever, bring them all into one space, report what core outcome sets they are and where people should be trying to use them, and where the gaps lie, where haven't core outcome sets been developed, and how do we ensure that researchers are using the core outcome sets that have been developed is also an issue. But yeah, that's one of the main pieces of MLTC work that I'm working on.
That's quite interesting. So I guess examples of that would be like the quality of life, quality.
Absolutely, yeah. If that's just one example, so we've got the quality of life measures, and there's so many different questionnaires that you can use to measure quality of life, that when we come to compare, say 10 studies have all measured quality of life and an MLTC intervention, it's then very difficult if they've used different tools to then do what we call a meta-analysis, is where we put all of the results together and create an overall summary statistic on, is it effective, is it not? We can't do that if they haven't used the same tools. And the same for any measure, whether it be like a blood measure like CRP, for example, or whatever it is that we're interested in. We need all of the researchers to be using like a universal tool or outcome. So for us to then bring all of the research together.
Yeah, it sounds really important work, actually. It sounds like you're doing quite good. Yeah, thank you very much, Lauren. And so last, Ash, what kind of things do you focus on? What's your interest in MLT?
Yeah, so similarly to Lauren, some of my work is more methodological, and that particularly focuses on who is involved in our MLTC research, and do the study samples represent the populations that are going to benefit or potentially disbenefit from the research that we do. Specifically, we've done a systematic review looking at multiple long-term conditions intervention trials globally, and looked at the ethnic groups that were represented in the study samples. Perhaps not surprisingly, they were primarily white, and there were limited proportions of non-white ethnic minority populations, which is concerning when we think about countries like the UK, which is increasingly changing in demographics. The work that we're doing needs to be applicable to the population. So that's primarily the area that I'm interested in.
Okay, that's really interesting. So I guess it's really honing down on who's involved in MLTC research and where could we find improvements and things.
Absolutely, and if we think about something like guidelines hopefully should be based on evidence. If that evidence base hasn't been generated on all in society, then people may negatively or positively be impacted. Depending on what the guidelines say.
Yeah, so that's good. It has quite direct implications. So it's really good. Yeah, very important. Yeah. So that.
What about you, Sham? What are you?
Yeah, so it was a good question. So I come from clinical background, so I've kind of trying to work with a lot of different researchers and kind of get different viewpoints and things and seeing where I can help. But one area that I'm interested in is sort of how often are we achieving the guideline. So guidelines will set targets like your cholesterol should be this or your blood pressure should be this and that. So how well are we doing? And I mean, the research tells us that doctors are achieving this about 50% of the time. So it's quite lower than you would expect. So it's why are we only achieving in 50%? So that's the kind of thing I'm looking at the moment. But yeah.
Interesting.
Thank you for asking.
That sounds interesting.
Yeah, so we've had a lot of interesting discussions. So I'd like to thank our panel. So it couldn't have been done without you guys. And so thank you, Deborah, Ash, and Lauren, for joining us today. And thank you, everybody, for joining us today and listening in. And please look out for our future videos on MLTC, and I'm sure we can have many more important and interesting discussions. Thank you.
Thanks for having us.
Thank you.
Thank you.